It's a great pleasure and honor to be here. It's my first time in Kuwait. I look very much forward to meeting you and seeing a little bit of your country. So today I'll be covering, between today and tomorrow, we'll be covering a wide range of urological pathology specimens throughout most of the organs between the lectures and the slide seminars. So I'll start with basically probably the most common specimen that you see in urological pathology, which is the evaluation of prostate needle biopsies. Prostate cancer worldwide is one of the most common diseases. So prostate cancer is very difficult to diagnose relative to many other entities, and that's for several reasons. One is prostate needles are very limited. It's a centimeter by a millimeter or less. We often see very limited cancer on the needle biopsy. And relative to other organ systems, and I practice general surgical pathology, all other organ systems, but relative to other organ systems, prostate cancer is often very subtle histologically. So what I'll emphasize today is how to use a systematic approach to diagnose prostate cancer. You don't just look at the slide and give a gestalt, but you should look at specific architectural, cytologic, and ancillary features. And with the exception of a few findings that are by themselves diagnostic of prostate cancer, most of the time when you diagnose cancer, it's based on a constellation of features. So what you do when you look at a slide, and often it happens within a second, but what you want to do is have a mental balance sheet. On one side of your brain are features that are favoring the diagnosis of cancer. On the other side, we'll deal with later in the lecture, are features that should make you step back from diagnosing cancer. So features that favor the diagnosis of prostate cancer, you always start first with an abnormal architectural pattern, and I'll go through what those are. You then turn your attention to the nuclei. Everyone focuses on prostate cancer with prominent nucleoli, but nuclear enlargement and hyperchromasia are also important features. Mitotic figures and actually more commonly apoptotic bodies are a feature that favor cancer. You then look at the cytoplasm, whether it's more amphiphilic relative to the normal glands. And then intraluminal contents are also important, blue-tinged and pink amorphous secretions. And probably less importantly, we'll talk about crystalloids. So first, in terms of just low power, in general, this is not how you want your prostate needle biopsies to come to you from your histotechnologist. I get consults from all over the country, and most of them are evenly spread apart and just several cores lined up. But sometimes you'll have cases where the cores will all be jumbled up, and the problem is you can have gaps in the tissue where you may be missing the key focus. So ideally, you want 2 to 3 cores maximum per block. There are some techniques in the United States where they now will put 6 cores in a block lined up in different channels. That's an option as well. In general, you do not want your urologist to submit multiple cores from one side, let's say the left side versus the right side. They should split them up into sextant sites. And the reason is, sometimes for therapy it can help when they do brachytherapy, which are the radioactive seeds. They evenly distribute it through the prostate, but if you know where the cancer is, for example, the left apex, they will put extra seeds in that area. So by having the urologist submit them in separate sites can be helpful. There are some times when the radical prostatectomy comes out and you have trouble finding the tumor. Knowing where the tumor was on the needle biopsy can also be helpful when you're sampling that radical prostatectomy. I'll talk about certain histological pitfalls in diagnosing prostate cancer and intraductal lesions in subsequent lectures. Some of these lesions occur preferentially in different areas. For example, the central zone up at the base of the prostate has some mimickers of prostate cancer. If you know the biopsy is from the base, that can be helpful. And I'll talk briefly at the end when you have something atypical, suspicious for cancer. Again, it helps urologists to know where that atypical focus is to redirect their biopsies. As I showed, if you just have 1 to 2 cores per slide, that helps for us better visualization of the core and reduce fragmentation. At Hopkins, what we do is we stain slides 2, 4, and 6, and we keep 1, 3, 5, and 7 unstained. So that if we see an abnormal focus on one of the levels, maybe it's gone on a later level, we have the intervening unstained sections that we can do special studies. And then in terms of fixatives, routine formalin fixation is perfectly good. The most important thing for prostate needle biopsies is having thin sections, because in order to see good cytological detail, good nucleoli, it has to be a thin section. So architecturally, there are several features that help favor the diagnosis of cancer. Again, they're not specific for cancer. One is the focus of crowded glands. So anytime you scan your biopsy, and I scan my biopsy typically at 4x, using the 4x objective lens. If you see a focus that's crowded, you want to look at it at higher power. Again, I will show you mimickers that have just as crowded glands as cancer. But nonetheless, crowded glands could be cancer, so you want to go down and look at it at higher magnification. What you then want to do is find, ideally, the glands that you know are benign. So if we look on the left, there are glands that we can recognize are benign. You then want to compare them to the glands that you're questioning, are they cancer? And look for as many differences as possible. And you can see here that many of these cancerous nuclei are much bigger than the benign nuclei. So nuclear enlargement is one of the features that we look for cancer. The other feature that makes all pathologists more comfortable sometimes diagnosing cancer are prominent nucleoli. But there are mimickers of cancer that have just as prominent nucleoli as cancer. So it's, again, one feature out of several, but not by itself diagnostic. The other issue that this slide highlights is the problem of looking for basal cells on the routine H&E section. It can be very difficult, almost impossible, to tell what's a basal cell on the H&E as opposed to a fibroblast. So this is cancer, but for example, this cell would be indistinguishable from a basal cell. These are just fibroblasts, but again, on H&E, without special stains, for the most part, I don't look for basal cells. The other architectural feature you look for at scanning magnification are small glands. Most cancers, the glands are smaller than benign glands. Again, there are exceptions I'll talk about later. But if here's your benign gland for comparison on the lower right, larger gland with infolding, these glands are smaller. And again, if you go to higher power and compare the benign gland to the atypical gland, there's nuclear enlargement, nucleoli. And this highlights mitotic figures. So it is not common to find mitotic figures in lower grade prostate cancers, the ones that you're struggling to diagnose. However, if you find a mitotic figure, it favors prostate cancer. Again, it's not specific for prostate cancer. Atrophy, as I'll talk about, can have mitotic figures. High-grade prostatic intraepithelial neoplasia can have mitotic figures. We also see this geometrical shaped eosinophilic structure, which is a prostatic crystalloid. More common in cancer than benign, but you can see them in benign glands as well. So again, it's just one feature by itself, not specific, but favors the diagnosis of cancer. I mentioned apoptotic bodies. Apoptotic bodies are actually fairly common in cancer and can help make the diagnosis of cancer. They're typically not seen in any other benign lesion. They can be seen in prostatic intraepithelial neoplasia, which we'll talk about in a subsequent lecture. But in the presence of small crowded glands, which would not be consistent with high-grade PIN, apoptotic bodies favors cancer. So as you can see here, this was a study I did quite a while ago. Mitotic figures are not that common, but apoptotic bodies much more common in cancer. Where the nucleoli are in the nucleus and how many nucleoli is not something that helps to favor cancer, so it's not something that I look for. Now, in addition to crowded glands and small glands, a more definitive architectural pattern for cancer is an infiltrative growth pattern. Now, you have to be careful when we refer to an infiltrative growth pattern in prostate cancer. I'll show you some mimickers of cancer that can look infiltrative, but when we talk about a specific infiltrative growth pattern that's almost pathognomonic for prostate cancer, what that means is you see an atypical gland, benign gland, atypical gland, benign gland, atypical gland. The fact that we have these atypical glands going in between these benign glands is something that you only see with cancer. So many times it's very helpful that if you're struggling on just a couple glands, is it cancer or not, finding the same atypical glands on the other side of a benign gland, that helps you to be definitive that it is prostate cancer. So here's a case that maybe you had this focus here, at higher magnification, you didn't see any nucleoli, you favored strongly it was cancer, but maybe you weren't 100% sure. The fact that you can see the same glands on the other side of the benign gland tells you it's an infiltrative growth pattern and allows you to make a definitive diagnosis of cancer. The final architectural pattern that's good for prostate cancer is a linear array of small atypical glands going across the core. That is not an anatomical pattern of benign glands, this linear growth pattern. You can also appreciate that these glands have darker cytoplasm relative to the benign glands. Very uncommonly, you diagnose cancer when you have nothing else other than the architectural pattern. But I would warn you to be very cautious in that setting, because as I'll show you, both on the slide seminar and on one of the photomicrographs, you can have adenosis, for example, occupying 90% or 100% of a core, looking as crowded as cancer, that if you just looked at it as a gestalt, you would say, oh, this has to be cancer, and you would be wrong. So you have to be extremely careful, and that's why you look for specific architectural and cytological features. But uncommonly, you can have a cancer that is very bland cytologically, where you have to make the diagnosis based on its architecture and with special stains. So here's a case where to the lower part is more benign tissue here. You can see larger glands, stroma, larger gland stroma. Then we can see this crowded glandular process here that is suspicious for cancer. But when you go to higher power, basically just very bland cytologically. This is a situation where you have to be extremely cautious, and I would not call cancer on the H&E, but sometimes in this situation, you can still diagnose cancer with the fact that you've lost the basal cells, and in here the red being the positive racemase, and the fact that it's infiltrating again in between benign glands. So adenosis, which is a mimicker of cancer that we'll talk about later, that can have very crowded glands, never has this infiltrative growth pattern in between the benign glands. Turning our attention to the nuclei, so sometimes you don't see prominent nucleoli, but hyperchromatic nuclei relative to the normal is still a feature favoring cancer. So here you can see these enlarged hyperchromatic nuclei relative to the benign glands is a good feature for carcinoma. Cytoplasm is very important, and in order for cytoplasm to be a good diagnostic criteria, you want to make sure that your benign glands have a very pale to lightly eosinophilic cytoplasm. Some of the consults I get, all the benign glands are dark cytoplasm, and you've lost that important potential diagnostic criterion. Here you can see small glands of cancer with very amphiphilic cytoplasm relative to the benign glands. Another case where, again, our benign gland is up here in the upper right. You can see that these glands have more amphiphilic cytoplasm. Another feature favoring cancer is a sharp, straight luminal border, whereas benign glands tend to have this ruffling of the luminal border. We also see blue-tinged mucinous secretions, which strongly favors carcinoma. Another type of secretion that favors cancer are these dense interluminal pink secretions. They differ from corpora amylaceae. Corpora amylaceae look like concentric rings of a tree. These are amorphic dense secretions, which again favored the diagnosis of cancer. And then something that typically many people ask me, do you need a minimal number of glands to diagnose cancer? Is there, do you need 3 glands, 4 glands, 5 glands? And from my standpoint, there is no minimum number. There are some times that I will diagnose cancer on 1 or 2 or 3 glands, and there are some times I will not diagnose cancer on 30 or 40 atypical glands because I cannot rule out, for example, adenosis. Ultimately, when you diagnose cancer, you have to be 100% certain, not 95, not 98. And so there are several things that I use to make sure that I am 100% sure. So if I'm looking at a case and I get about 30 to 40 consults a day from around the country and sometimes outside the country, but if I go on to the next case and I'm thinking about the case I just diagnosed, I say stop, get that case back, let me look at it. Am I 100% sure? If I'm 100% sure, I go on, I don't think about it. But if I bring it back and I think something bothers me, I'm just not 100% sure, you don't diagnose cancer. Even worse, if you're driving home after a day and you're thinking about a case, you shouldn't be. Even worse, going to sleep thinking about a case, you're worrying about it, that's not good. You should be 100% confident. Some cases you work, you struggle, but at the end of it, you're sure. In the next case, you don't even think about it. As a pathologist, we're not allowed to make a single mistake, especially in terms of overdiagnosis. But in this case here, we had a single atypical gland. There was a benign gland on the top and on the bottom. And we had a mitotic figure, crystalloid, dense pink secretion, bluish mucinous, hyperchromatic nuclei, multiple features favoring cancer. So when you have often just a few atypical glands, in order to feel comfortable diagnosing cancer, you often need multiple of these atypical features that would be impossible in a benign gland. The times that I'm most comfortable diagnosing cancer on just a few malignant or atypical glands is this situation, where I have a benign gland, another benign glands around it, and then an atypical gland that's tightly packed in between here. This gland is amphiphilic cytoplasm, some enlarged nuclei, dense pink secretion. There's nothing benign or even precursor premalignant lesion that would have this appearance. High-grade pin would not be a gland tightly tucked in between a benign gland. High-grade pin is pre-existing benign glands with atypical cells. So seeing this gland tightly in here, basically that can only be cancer. And this is a pin 4 stain showing absence of basal cells and positive racemase, which, again, in this setting, you can see mimickers that could lose basal cells and have racemase. I'll talk about that later. But nothing like this tightly in between two benign glands. That has to be prostate cancer. So there are some, so far I've talked about features that favor the diagnosis of cancer, but by themselves are not pathognomonic. There are some features that if you see them, no matter what, it has to be prostate cancer. One is perineural invasion, one is glomerulation, mucinous fibroplasia, and extravasated mucin. So sometimes you're looking at a prostate needle biopsy, and you'll see a gland that at low power looks maybe benign, it has some infolding, but it's off all by itself, and you see a little pink thing in the middle. When you see that, you want to go down and look at it at higher magnification, because there's an entity which I described called kind of pseudohyperplastic perineural invasion, where the glands look almost like a benign gland, but they're wrapping around a nerve. That is diagnostic of prostate cancer. Only cancer circumferentially of 180 degrees, 368 degrees, wraps around a nerve like this. We'll talk about some mimickers that can partially go around a nerve, but when you see a gland going entirely around the nerve, again, that's cancer. So as I mentioned, the pitfall is sometimes you can have perineural and intraneural involvement by benign prostate glands. So these are benign glands of the prostate. We'll talk about partial atrophy, but this is a gland of partial atrophy. But if you compare this gland to all the glands around it, same benign nuclei, same light cytoplasm, but you can see they're pushing in a nerve. And benign glands can do that. It's totally consistent with a benign process. So when we talk about the relationship of prostate glands to nerve, it's important whether we're talking about using perineural involvement as a diagnostic criteria versus a prognostic criteria. So sometimes you will see prostate cancer, straightforward, obvious prostate cancer, doing this, pushing in a nerve. When you see prostate cancer, that you have no question it's cancer, pushing in a nerve, we call that perineural invasion. If it's tracking along the side of the nerve, pushing the nerve, wrapping around the nerve, even partly, that's perineural invasion with prostate cancer, and that ends up being prognostically important. Even some new data shows that for men on active surveillance, it's a worse feature. But if you're using it to diagnose prostate cancer, you're using perineural invasion to diagnose cancer, you're not sure it's cancer, and the only way that you would call it cancer is if it's perineural invasion, your criteria for what is called perineural invasion becomes much more stringent. In that situation, you want to see the glands wrapping totally around the nerve, not just pushing the nerve. because, again, benign glands can push the nerve. Here we see another benign gland partially going around a nerve. You can see this gland, it's going not entirely around the nerve, but partly around the nerve. But again, this gland is an entirely benign nerve gland. Here are the basal cells. This is another case of a benign gland going around a nerve, almost around the nerve, but not quite. Again, this is an atrophic benign gland with perineural involvement. And here are the basal cells, and here's the nerve, and you can see that these are benign glands. And sometimes you can actually see even benign glands in the middle of a nerve. So just to be aware, that doesn't mean it's cancer. Mucinous fibroplasia is also diagnostic of prostate cancer, even if there's nothing else that you're comfortable to make the diagnosis. And the reason I call it mucinous fibroplasia is you often see that blue-tinged mucinous secretion, and then you start seeing this delicate collagen growing into that mucin. Here it becomes a little bit more organized, where you see the blue mucin and then these collagen bundles. And sometimes it becomes more even collagenized, where you get these fine little, almost like thread-like collagen little bundles. But when you see this, for example, this case would be a difficult diagnostic case. It's very atrophic, not a lot of cytologic atypia. But the fact that we see these little bundles of mucinous fibroplasia here, it tells you that this has to be prostate cancer. There's no benign glands that has this mucinous fibroplasia. In contrast to many other organs, we can see mucocele-like reactions in breast cancer, for example. In the GI tract, we get mucin extravasation with benign glands. In prostate cancer, you do not get mucin extravasation with benign glands. So if you see some small glands, atypical glands, suspicious for cancer, with extracellular mucin, that has to be prostate cancer. And here, just demonstrating the absence of basal cells, positive racemase. Glomerulations, we'll talk about that in grading of prostate cancer. It's basically a cribriform process, protruding or poking into a dilated gland. You only see this in cancer. So let me turn to now some cancers that are more difficult to diagnose. These are pseudohyperplastic prostate cancer, foamy gland prostate cancer, and atrophic prostate cancer. So pseudohyperplastic prostate cancer is a relatively unusual variant of prostate cancer. And the reason why it's difficult to diagnose is the glands are architecturally more benign. So when we think of benign prostate glands as opposed to cancer, we think of larger glands, glands with papillary infolding, branching glands. That's what you see in pseudohyperplastic prostate cancer. So this is a difficult case. So when you have a difficult case, the first thing you always want to do is say, where are the glands that I know are benign? So if we look at this field, the ones that I'm comfortable are benign are on the left. They're larger glands with infolding, some branching. They have a fair amount of stroma in between. So on the left, those look like benign glands. On the right, we're getting mixed signals. The glands are fairly large, just as large as some of the benign glands, much larger than the typical glands of prostate cancer that I showed in previous slides. Some of the glands have infolding, but this focus is more crowded. Also, as we'll show at higher power, some of these glands have a sharp, straight luminal border, despite the glands being fairly large with a lot of cytoplasm. So then we go a little bit higher magnification. This gland has, again, mixed features. It's a large gland, which we tend to associate with more of a benign prostate gland. But for a large prostate gland, most large benign prostate glands have a lot of luminal infolding or ruffling to the luminal border. This one has a very sharp, straight, razor edge border. That favors cancer. But then we see some of these glands do have this infolding, which is more of a benign feature. So again, mixed features. And then we go to higher power. In order to diagnose pseudohyperplastic cancer, you need prominent cytologic atypia. You need to see prominent nucleoli. Because architecturally, it has many benign features. You need the malignant cytology to establish a definitive diagnosis. Now, still in the differential diagnosis of this lesion would be high-grade prostatic intraepithelial neoplasia, because some of these glands are large with infolding with cytologic atypia. And then you do the basal cell stains. So what you want to see when you do the basal cell stains is that the glands that you thought were benign or have the basal cells, the glands that you were questioning, are they cancer, are all negative. Now, in this focus, if I started to see some patchy staining, a few cells positive, I would not call it cancer. I would call it atypical, suspicious for cancer. But the fact that all of these glands are entirely negative, and on the H&E, those areas were suspicious for pseudohyperplastic prostate cancer, you can make a definitive diagnosis. Foamy gland cancer resembles benign glands not so much on the architecture, but the cytology. Foamy gland cancer has very bland cytology. The nuclei do not have prominent nucleoli. As I'll talk about grading, foamy gland cancer can be Gleason pattern 3, pattern 4, or pattern 5. So foamy gland prostate cancer will always have crowded glands. So that's your first architectural pattern you think of. Another feature in foamy gland prostate cancer is they often have those dense intraluminal pink secretions. That's a common feature. And then when you go to higher power in foamy gland prostate cancer, that's when you start becoming uncomfortable calling it cancer. And that's because the nuclei just look totally innocuous, totally bland, small, round nuclei with absent prominent nucleoli. But the key feature is the foamy cytoplasm. It's this voluminous amount of cytoplasm where you have 4 to 5 times the amount of cytoplasm relative to the nucleus, in contrast to benign prostate glands where maybe the nucleus occupies 1/2 of the cell height. Sometimes you can appreciate in foamy gland prostate cancer, it almost has a xanthomatous or microvesicular appearance, again with this huge amounts of cytoplasm. But what you also notice in foamy gland cancer is that if you see usual prostate cancer adjacent to the foamy gland cancer, the usual cancer will have prominent cytologic atypia, but abruptly when you get to the foamy gland cancer, there's no cytologic atypia. So there's something unusual about that foamy cytoplasm that it's typically associated with just very bland cytology. Here's a case that literally in the same gland, we have some nuclei, some areas, some cells without foamy cytoplasm and some cells with foamy cytoplasm. And you can see that the cells without the foamy cytoplasm have big nucleoli, and once you hit the cells with the foamy cytoplasm, very bland cytology. So again, they always go together. Atrophic prostate cancer is also extremely difficult sometimes to diagnose. Sometimes you can see it in patients who've had hormone therapy, but most of the time when you see atrophic prostate cancer, there is no history of anti-androgen therapy. So to diagnose atrophic prostate cancer, you need one of these 3 features. Either a truly infiltrative growth pattern, like I talked about before, but I'll illustrate again, huge nucleoli beyond what you can see in atrophy, and sometimes you can diagnose it by the company it keeps because it merges with non-atrophic prostate cancer. So this is a difficult case, a diagnosis of atrophic prostate cancer. Again, we want to find the glands we know are benign. Here we see these nice large glands with infolding. There's another benign gland. And we see all these small glands, but very atrophic cytoplasm. But it has still a very infiltrative growth pattern. So we see the atrophic glands here, here, and here. Atrophy never infiltrates like we see here on both sides of the benign glands. But at higher power, again, there's just no cytologic atypia at all. So at higher power, this could be benign atrophy, but that growth pattern where it's going on both sides of the benign glands has to be prostate cancer. And when you do the basal cell stains, again, you can see these glands infiltrating in between the benign glands and on both sides of the benign glands. That's diagnostic of prostate cancer. Here's a case of atrophic prostate cancer with huge nucleoli, looking like a seminoma or melanoma type of nuclei. You don't see that in atrophy. Another case of an atrophic prostate cancer where you have some of the glands very benign looking, but again, some with big nucleoli that basically says this has to be prostate cancer. And then sometimes you have atrophic prostate cancer that by itself you would never be able to diagnose. For example, this gland here you would never be able to recognize as cancer. But then you come to this gland, you start seeing, well, there's one nucleus that looks atypical. You come here, and now it's still atrophic cytoplasm, but overtly cytologically malignant. And then we start having more cytoplasm and typical prostate cancer. When you do the special stains, all of this is cancer. But this is cancer, in a sense, only in the context that we can recognize it next to more typical prostate cancer. So I've talked about features favoring the diagnosis of prostate cancer. I also mentioned now that in your mind you should have a balance sheet of things that make you step back from calling cancer, or at least questioning, could it be cancer? So some of the features that should make you being concerned to diagnosing cancer: one is atrophic glands, because you could have benign atrophy mimicking cancer, where you have small crowded glands merging in with benign glands, which I'll talk about adenosis. Corpora amylacia you can see in about 10% of prostate cancers, but it's much more common in benign glands, so you should think twice about calling cancer with corpora amylacia. It's very uncommon to see cancer with inflammation. It happens, but it's rare. Prostate cancer and inflammation are like usually oil and water. So if you see small atypical glands with a lot of inflammation, again, you should be extremely cautious to call cancer unless it's obvious cancer. And then I'll talk about when you have PIN next to atypical glands, you also have to be more cautious calling cancer. So let's go through some of the more common benign mimickers of prostate cancer. One is atrophy. And there's several different patterns of atrophy. One pattern is called post-atrophic hyperplasia, or PAH. And those are glands that look very blue at low power. And the reason why they look blue at low power is you're basically only seeing the nuclear outline of the gland. There's very little cytoplasm apically, very little cytoplasm between the nuclei. So all you're really seeing at low power are nuclei, and that's why it looks blue. And you can diagnose post-atrophic hyperplasia at scanning magnification. If you see blue glands, nice well-formed lumina, that's atrophy. If you go to higher power with atrophy, you can actually get confused because atrophy can sometimes have some small nucleoli, not the huge nucleoli that we saw with some atrophic cancer. And the word post-atrophic hyperplasia actually is accurate scientifically. Even though these glands are atrophic, they are actually proliferating. If you do a Ki-67, they're actually increased, and you can see mitotic figures in atrophy. The good thing about post-atrophic hyperplasia is that it tends to be diffusely positive for basal cell markers, high molecular weight cytokeratin or P63. Some patterns of atrophy that can cause more difficulty, there's one called sclerotic atrophy, where it's associated with a dense sclerotic stroma, where the glands can look more haphazard and infiltrative. But the key thing is to remember that these glands look infiltrative in a patch. They look infiltrative just by themselves, but they're not infiltrating in between the benign glands like I showed you with atrophic prostate cancer. And in fact, when you see this kind of sclerotic stroma around glands, that favors benign. Prostate cancer usually has no desmoplastic stromal reaction. And when it has a stromal reaction, it's a cellular stromal reaction, not this sclerotic hypocellular collagen. Hypocellular collagen around glands typically is seen with atrophy. Another pitfall with atrophy is if you think of prostate cancer, some of them are cylinders or pipes. You can imagine shearing the top parallel to the pipe, just the surface of it, and you can get, if it's an atrophic gland, a structure that looks like this, where you have these very bland nuclei, very scant cytoplasm, but they're going to make these cylinders or columns. That's not a pattern that you see with prostate cancer. That's just post-atrophic hyperplasia tangentially sectioned. Another common pattern with post-atrophic hyperplasia is to see a central gland surrounded by this sclerotic collagen, and then with this proliferation of these small atrophic glands around it, giving this very lobulocentric unit. That's classic for post-PAH. Now, by far and away, the most common mimicker that I see in my consult service that pathologists have difficulty with is partial atrophy. And partial atrophy is difficult in several regards. It looks totally different than post-atrophic hyperplasia. The glands don't look blue. They look like they're pale glands at low power. The glands can be very crowded, just as crowded as any cancer. The key thing, and you can diagnose partial atrophy typically, for example, at this magnification or even lower magnification. Because when I look at this, I see very scant cytoplasm at the luminal surface. I see a lot of cytoplasm between the nuclei laterally. And I see that these glands have a kind of ruffled luminal border. It's a little subtle, but it's not that sharp, straight border that I showed you with cancer. It's this little undulating cytoplasm, a little raggedy cytoplasm on the surface. That's classic partial atrophy. Nuclei can be slightly enlarged, maybe small nucleoli, and you don't want to pay any attention to glands that, or where you see maybe a cluster of just a few individual cells without gland formation. They're just tangential sections off of the partial atrophy. Here at higher power, nuclei goes almost up to the top of the cell, so again, they're atrophic cytoplasm. A lot of cytoplasm between the nuclei, and then again, that little ruffling of the luminal border, ragged luminal border. The problem with partial atrophy is with the basal cell stains and racemase. So in partial atrophy, you can see typically just very patchy staining. So first of all, many glands will be entirely negative, and the ones that are positive often just have a few cells that are patchy positive. But what you have to do when you look at a case of partial atrophy is to say, are the glands that are negative, do they look identical on the H&E to the glands that are patchy and positive? If the entire lesion looks the same, and some glands are patchy and some are negative, then it's all benign. Here's another case of partial atrophy. So again, partial atrophy will stand out. It'll look different than the surrounding glands. Different doesn't equal cancer in prostate pathology. You want to look at it if it looks different and assess it, but ultimately, some of the benign mimickers can look like cancer at low power. But here we see this focus of crowded glands. And when you go to higher power, again, classic partial atrophy, scant cytoplasm at the surface, a lot of cytoplasm laterally, little ruffling to the luminal border. And you can see it's kind of merging in this case, with some partial atrophy. Here we also see corpora amylacia, which favors benign. And again, one basal cell here, a couple basal cells, another. Very patchy, but many glands negative. All the glands that are negative are the same as the glands that are patchy. The whole lesion is benign. Here's another case of partial atrophy, classic partial atrophy. And these cases that I'm showing you of partial atrophy with special stains, these are cases that were sent to me where the outside pathologist had done the stains. If I had looked at these cases just in my own practice, I wouldn't do the stains because they looked like partial atrophy. But just to explain to you the pitfalls with the stains, if you do the stains, so here's a case, again, no question it's partial atrophy, scant cytoplasm, benign cytology, ruffling of the luminal border. But if you look at this, it stains basically indistinguishable from prostate cancer. No basal cells, positive racemase. So if you relied on the stains by itself, you would end up with a misdiagnosis. That's why with prostate pathology, 95% of the diagnosis is the H&E. Your special stains can be adjuncts, but if you use your special stains out of proportion to the H&E, you will make a misdiagnosis occasionally. So basically, again, in this case, I wouldn't have done the stains, but if you do the stains and you get this, you still don't call it cancer. Another case of partial atrophy, again, classic glands, large glands, infolding, totally benign. And again, stains like cancer. There's actually maybe one little basal cell here, but the rest negative. So again, it's a major pitfall. Another major pitfall is adenosis. Adenosis is also a pitfall in that it's often multifocal, even on a needle biopsy. So if you see one area on a needle biopsy, you think, I'm not sure, is it cancer or not? And then you see another focus, you can't use that as an argument to say it's cancer. It could be multifocal adenosis. The reason why adenosis is difficult on a needle biopsy is it has a very lobular, rounded architecture. And you can appreciate that on a TURP or on a radical prostatectomy, but on a needle biopsy where you go into the middle of the lesion, you really can't appreciate its lobularity. And as I mentioned, adenosis on a needle biopsy can look just like cancer at low power. So here we see one of the more florid examples of adenosis on needle biopsy. And I'm not showing this to scare you. I'm showing it just to show you how, it can look just like cancer. But what should make you stop from calling this cancer at low power, at least questioning, could it not be cancer? And the key thing is up here, for example, if you look, some of these glands have some infolding, some branching. This looks like these could be maybe more, a little papillary infolding here. This looks like it could be more crowded benign glands. Down here, it looks maybe more like it could be cancer. But as we'll see, all of these glands look identical and they all merge together. And that's what you get with adenosis. Little higher power, here are some of these glands that look more benign with this little infolding. Here are some of the more crowded glands that, you're questioning, could it be cancer? Then you go to higher power. And again, what you want to do at higher power, find the glands that you know are benign, compare them to the glands that you think might be cancer. So here we look and we say, okay, I think this gland is benign. It's totally benign cytologically. It's large. It has all this infolding. Here are these small crowded glands. Could they be cancer? But when you compare the nuclei, the cytoplasm, they're indistinguishable. They all merge together. That's when you have to question, could this be adenosis? When the small crowded glands basically just merge in with glands that look more benign with the same exact cytological features. This is a P63 stain that was done on the outside pathologist. And we can see the same problem that we have with partial atrophy, you have with adenosis, meaning you get very patchy staining and not every gland will stain. So there will be some glands that are negative, some glands just one cell, some glands maybe a few. But the ones that are negative look identical to the ones that are patchy, just the same logic we used with partial atrophy. The whole lesion is benign, including the ones that are negative. Now, another mimicker of prostate cancer can mimic high-grade prostate cancer, and that's nonspecific granulomatous prostatitis. So the pitfall with nonspecific granulomatous prostatitis is clinically it mimics cancer. The rectal exam is hard, indurated. It can actually feel like it's extending out of the prostate because nonspecific granulomatous prostatitis can go outside the prostate. On imaging, MRI, ultrasound, it looks like cancer. PSA can go up to 30. It can be very elevated. The other pitfall is that most types of nonspecific granulomatous prostatitis do not look like cancer, and I'll show you examples of that. But there is this rare epithelioid variant that we described that does look like cancer that you have to be aware of. So most cases of nonspecific granulomatous prostatitis, don't even look that granulomatous. And it definitely doesn't look like cancer. It's very polymorphous. You get eos, neutrophils, and then you get these histiocytes, which is where the term comes, nonspecific granulomatous prostatitis. Some of them start looking a little bit more granulomatous, but again, you have these eos and polys. I wouldn't do special stains on a case like this for organisms. Again, doesn't look like cancer. But then you come to this epithelioid variant of nonspecific granulomatous prostatitis. So it looks very different than the other examples I showed you that look more overtly inflammatory. And if you're not aware of this variant of nonspecific granulomatous prostatitis, it looks extremely like cancer. I mean, you could, look at this and start using your imagination and saying these are poorly formed glands, there's some nucleoli in here, and you're on your way to misdiagnosing this as a high-grade prostate cancer. So what is the clue to prevent you from diagnosing this as a high-grade prostate cancer? And the clue is the presence of admixed inflammatory cells. As I mentioned before, prostate cancer and inflammation typically are not seen together. So if you see something that you think is high-grade cancer, but there's admixed inflammation, you should always ask yourself, could this be nonspecific granulomatous prostatitis? Because prostate cancer should not have these neutrophils scattered throughout. Another clue to nonspecific granulomatous prostatitis is they result from a ruptured gland. So you can see here there's this gland here with an atrophic cytoplasm with these foamy histiocytes in the middle. And you can see that these epithelioid histiocytes are surrounding this ruptured gland, which you wouldn't see with prostate cancer. If you are trying to decide, if something is prostate cancer or inflammation, the best stain to do is a CAM 5.2. Not a PSA, not an NKX 3.1, not a keratin AE13. And that's because high-grade prostate cancer sometimes are keratin AE13. They can be negative. But CAM 5.2 is always positive in benign glands, prostate glands, and in cancer glands. So this is a case of nonspecific granulomatous prostatitis. The CAM 5.2 is surrounding this benign gland, and all these histiocytes are negative. But one of the cases that I saw where a pathologist had misdiagnosed nonspecific granulomatous prostatitis and called it high-grade prostate cancer, they had done a PSA stain only. And the PSA stain had nonspecific weak staining in the histiocytes, and they used that to diagnose or misdiagnose prostate cancer. So what you want to do, again, if you have a question, are these histiocytes or is it cancer, do a CAM 5.2 on one side, but also do a CD68. Because if you do that, all these histiocytic cells will be strongly positive, and that should also make you step back and say this is not prostate cancer. I mentioned how you have to be careful when you see high-grade prostatic intraepithelial neoplasia, and we'll talk about that in a separate lecture, with adjacent atypical glands. And I use we often use Cantex or macros, and we have like 200 of them in GU pathology, where we just put 3 letters and it spits out a paragraph. This is our pinnate tip, basically macro, where we say high-grade pin with small focus of atypical glands. See note. A note is adjacent to glands of high-grade pin or a few small atypical glands. While these small glands may represent a small focus of infiltrating cancer, we cannot exclude they represent outpouchings or tangential sections off of adjacent high-grade pin. So that scenario comes into play when you see a gland that are small glands suspicious for cancer, but they're adjacent to larger glands of high-grade pin that are pre-existing benign glands with infolding, big dilated glands. In that scenario, you have to be more cautious calling cancer because it could just be a tangential section off of the high-grade pin. Now, when you look at higher magnification, these are the high-grade pin gland on the top. These are the questionable cancer on the bottom. High-grade pin and cancer have identical cytology, just like any other in situ and infiltrating cancer in the body. So cytology is not going to be what distinguishes cancer from high-grade pin. It's the architectural pattern. Do you have too many small glands that are not potential to be an outpouching off a pin? So what you want to do in this situation is do a basal cell stain. And when you do a basal cell stain, you can see that many of these small glands are patchy. Now, a few of them are negative, but there are too many here to be patchy. So in this case, this is pinnate tip. I would not diagnose this as cancer. I'd say high-grade pin with adjacent atypical glands. But on the H&E, this is highly suspicious for prostate cancer. But again, when you have adjacent high-grade pin, you have to be cautious and do the basal cell stains. Here's another case where we have high-grade pin on the bottom. We see these small glands trailing off to the top. Again, you would do basal cell stains, and when we do the basal cell stains here, we can see this one gland has some basal cell stains, but it's immediately next to the pin. And then we see all these small glands without basal cell stains trailing away from the pin. And what you have to ask yourself, are there enough small glands that have no basal cells, and are those small glands without basal cells far enough away from the pin that this cannot be explained as a tangential section off a pin, but in fact this has to be prostate cancer? And when I look at this slide here, I would say we have too many small glands. Small glands are too far away from the pin. I'm comfortable this is a small focus of cancer adjacent to pin. Here's another case where you have a lot of high-grade pin. All of these bigger glands are high-grade pin. We see a small cluster of small glands. Is this cancer with pin, or could this be outpouchings of pin? And we do the stains. Now, in this case, there's another criteria that I use to help me diagnose cancer. The glands here are not that far away from the pin, and there aren't that many glands, but what enables me to call this cancer in this particular focus is that the high-grade pin has an intact basal cell layer. All of the high-grade pin has intact basal cell layer, so these cannot be outpouchings off a pin. Sometimes you'll see high-grade pin where they have a very kind of a patchy basal cell layer. Those are the kinds of high-grade pin that you have to be careful diagnosing cancer next to it. But when you see small glands without basal cells adjacent to pin where the pin has an circumferential intact basal cell layer, you cannot attribute these glands to an outpouchings off of the pin. This has to be prostate cancer. So let me explain a little bit, and you probably get a sense of how I use basal cell markers. If I see something atypical and I favor it's cancer, maybe I'm 90% sure it's cancer, but not 100%. If the basal cell stains are negative, that gives me that extra 10% to be able to call it cancer. If I see something atypical, but I'm favoring it's benign and it's negative, I might end up calling it atypical. I probably won't call it cancer. If something's benign, I don't do the stains, but often in my consults, for example, if I see something benign and it's negative staining, I still call it benign. So here's a case of, I think, how using the basal cell markers can be helpful in diagnosing a subtle focus of prostate cancer. So here again, we find our glands that are benign. This gland looks benign, no atypia infolding. This one looks benign. And then we see a crowded focus. But the cytoplasm in this crowded focus pretty much looks the same as the benign glands. There's some subtle small nucleoli, but not huge. So on H&E, this would be suspicious for cancer, but I wouldn't feel comfortable being definitive for cancer. When you do the special stains, basal cell markers, high molecular weight in P63, totally negative in those small crowded glands tucked in between the benign glands, I would use that to be definitive to say this is prostate cancer. Pitfalls with basal cell markers, I've kind of alluded to some of them already. Even if you just take benign prostate tissue, totally benign, and put a basal cell marker, high molecular weight, or P63, you'll see some benign glands just not staining. But more importantly, adenosis, partial atrophy, high-grade pin often has patchy or negative staining in some of the glands. Also, some cancers can stain with basal cell markers non-specifically. I'll show you an example. And extremely rarely, there are some cancers that express basal cells. But here's a case, another pitfall with basal cell markers. There's a variant of prostate cancer that we describe that has aberrant P63 positivity. It's where the cancer diffusely stains with P63. So here we see on the right, there was a cocktail of high molecular weight keratin and P63. So if you look at the benign glands, the P63 is staining the nuclei, but you can see there's little tails of cytoplasm for the high molecular weight keratin. So these are all the benign glands. But then this, you can see, looks different. Up top, there are small glands. You're only seeing the nuclei of the P63, no high molecular weight. That's an aberrant P63 prostate cancer. It becomes more obvious if you stain the slide only with high molecular weight keratin. You can see now the nuclei are empty here. There's no P63 in the benign glands. But you can see the cancer glands basically are negative for high molecular weight. So be aware that there is this P63 aberrant prostate cancer. And then we have some prostate cancers, as I mentioned, that can have non-specific staining for basal cell, but not in a basal cell distribution. So these are benign glands here. These are cancer glands here with this amphiphilic cytoplasm, and I'm going to focus just on this gland here, this cancer gland. So here, this is the high molecular weight cytokeratin stain. Now, if you look in the benign prostate gland, you can see the high molecular weight cytokeratin stains the basal cell flattened beneath benign secretory cells. So that's what we call a basal cell distribution, 2 cell types. But here we see this cancer gland. It's not in a basal cell distribution. It's not flattened cell like we see in the benign gland. It's staining the cancer cell non-specifically. And we can see that especially in high-grade cancers, but even in some lower-grade cancers. If you now do a P63, those same glands, totally negative. Racemase also is useful as a marker for prostate cancer, but also has its pitfalls. It's more common in cancer than in benign. Here we see a case that I think racemase was helpful. Here's a little cluster of glands that are suspicious for cancer, but cytoplasm looks similar to the benign, not marked atypia. So maybe you're favoring cancer, but not 100% sure. You go to higher power. Yeah, there's some nucleoli, maybe not huge nucleoli. you're like 90% sure it's cancer now. And then when you do the basal cell stain and the racemase, it lights up with the racemase, negative for basal cells. That gives you that extra 10% to be definitive to calling it cancer. Problems with racemase, basically similar to the problem with the basal cell markers. It labels high-grade PIN. Occasionally can stain benign gland, but more problematically, racemase does stain often partial atrophy and adenosis. Also, not all cancers are positive for racemase. About 20% will be negative, so false negative staining. And then I mentioned the more difficult to diagnose prostate cancers, foamy gland, atrophic, pseudohyperplastic prostate cancers. They are less frequently positive with racemase than other cancers. About 25 to 35% of them may be negative for racemase. So let me end this talk with discussing atypical needle biopsies. So first of all, I don't use the term atypical hyperplasia. It's a very non-specific term. A clinician won't know what you're referring to. It could be PIN, could be intraductal cancer. They don't know what that means. The other term that some pathologists use is atypical small acinar proliferation, or ASAP. There's nothing wrong with that term. The only problem is some clinicians, again, think it is a specific disease entity, when in fact it's not a specific disease. It's more of a state of uncertainty by the pathologist that we're not sure if it's cancer or a mimicker, or maybe there's just not enough glands. So I typically sign out my biopsies more, the ones that are atypical descriptively. Again, this is just a canned text that we use, macro. But we say it's small focus of atypical glands. And we say, although the findings are atypical, suspicious for low-grade adenocarcinoma, there was insufficient cytologic and/or architectural atypia to establish a definitive diagnosis. So it's totally clear to the clinician what we're referring to. And then we say follow-up was warranted with either serum or urine test imaging, and in some cases, repeat biopsies with relative increased sampling of the atypical site. I used to have in this note, repeat biopsy is recommended. And the reason why I stopped putting that in and made it more as an option, not necessarily as a recommendation, is there are some clinicians, at least in the United States, that if they get something atypical suspicious for low-grade cancer, they won't do a repeat biopsy. And their rationale is, yes, there's an increased risk of cancer, about 40%, as I'll show you. But they say most of the cancers that are found are low-grade cancers where the patient, might be on active surveillance, and so they don't even want to find those cancers. From my standpoint, I think it is, and when I talk to urologists, I recommend they do a repeat biopsy because, number one, I would want to know if they have cancer and be followed on active surveillance rather than not even knowing what's going on with them. And also, some of them do have higher grade cancer, and you don't want to miss those patients. But it's controversial in terms of what the urologist does in this setting. Now, occasionally, as you note in this case, I specifically say suspicious for low-grade cancer. Those are the cases with very small focus of just well-formed glands. You're not sure if it's cancer. Occasionally, you may see something suspicious for higher-grade cancer, Gleason pattern 4. In that setting, you have to be very careful and say there's a focus suspicious for higher grade or suspicious for Gleason pattern 4 cancer. But in those cases, you definitely want to make sure the urologist does a repeat biopsy. This would be a case that I would call atypical. So at lower power, it's very atrophic. The glands are small and crowded. Could be partial atrophy, but nuclei a little bit more atypical, some little crystalloids. I'm not sure. And they're totally negative for basal cells. Now again, if this was a classic partial atrophy, negative for basal cells, I would call it partial atrophy. But because it's not typical partial atrophy, but it's still atrophic, I would call this atypical. Suspicious for cancer, cannot rule out atrophy. Here's a case, crowded glands, very bland cytologically. Here's a gland that's benign. Here's a benign gland. They look kind of similar. When you do the basal cell stain, there's like one basal cell here, maybe one here. A lot of them are negative. I would probably call this atypical. Cannot rule out adenosis. Here's a gland that looks like PIN, a large gland with infolding. Doesn't look like typical prostate cancer, but it's all negative for basal cells. There actually is a couple basal cells here, and these glands look similar up here that are negative. So this could be pinned with just very patchy basal cells, and in a plane of section you're not seeing them, but I would call this atypical, cannot rule out high-grade pin. And then sometimes I will call something atypical, especially when it's on the edge of the core. The problem with glands on the edge of the core is you don't know what's next to them. You don't know if there's part of an adenosis next to them, or maybe there's some high-grade pin next to them. So I'm more cautious calling a cancer when it's only a few glands on the edge of the core as opposed to in the middle of the core. Also, as I mentioned, with inflammation, you have to be careful calling cancer. So this focus here, there's some nucleoli, but again, inflammation can cause nucleoli. There's some a few polys in here. I would call that atypical. And then sometimes you call it atypical because there's just not enough glands. So here there's one gland that's atypical, but it's not tightly tucked in between that benign gland like I showed you earlier. Most likely this is cancer, and I would probably say it's highly suspicious for cancer, but I wouldn't call cancer on this to one gland in this setting, even if it's negative. Again, probably is cancer, but I would say highly suspicious for cancer. Again, we're on the edge of the core here. You would think, oh, this should be cancer. There's some good nucleoli. But again, on the edge of the core, you have to be careful. The outside contributor had done a basal cell marker, and these are patchy for basal cells. So it shows you why, in this case, you shouldn't be calling it cancer. So again, be cautious with atypical glands on the edge of the core. Again, how often should you be diagnosing something atypical? About 5% of your biopsies. Again, the risk of cancer is about 40%, which is more, it's a higher risk than if you had a benign gland, for example, with elevated PSA. And when I tell urologists how to rebiopsy patients who have atypical, most cancers, when you have, let's say, an atypical in the left apex, most cancers will be in the left apex because when we call something atypical, it's often cancer that we're just not comfortable calling. So it makes sense that on repeat biopsy, the cancer will be near that area that we called atypical. And that's why, again, I think it's important for the urologist to separate their biopsies, apex, mid, base, left, and right. So to summarize, with exception of a few findings that I mentioned, usually when you diagnose prostate cancer, you base it not on a single feature, but you base it on that mental balance sheet, a constellation of features. You weigh features for cancer and against cancer. And hopefully what I've been able to do with this lecture is kind of lower your threshold for calling cancer, but at the same time sensitizing you when not to call cancer and when to back off from calling cancer. But to recognize that even in the setting of a few atypical glands, if you have several features for cancer, nothing arguing against cancer, you can make a definitive diagnosis, again, on relatively limited tissue. This is now our 6th edition of the Prostate Biopsy Interpretation book. Thank you.